Just 30 seconds.
So till now we have had a series of lectures which have basically covered on how to get a sample out of the lymph node. But still I would say that EBUS is one technique, despite it being there around for almost more than 2 decades. There are several questions which still remain unanswered, where still probably there is a variation in the way we practice, the variation in which each center practices. We have heard from Dr. Titivat how they do EBUS at their center. So there are differences in several things, starting from contraindications, the way anesthesia is given, the number of passes, the number of revolutions, and so on and so forth. So brief discussion with the experts we have today on some of these areas where there is variability, and just to understand how it is. So I would request the faculty to come forward. Dr. Titivat, Dr. Valiyappan, Dr. Saurabh, Dr. Pavan, Dr. Kedar, Varun, Nitesh, everybody, whoever can come. Some people can come on the stage, some people can come on the moderator's podium. Samir, Rohan, I think you can just come over there. Don't just be there. Na? So this is just for us to understand how variable can the procedure be at various centers. Can I have the mics on the stage, please? So whoever is there, I think please have this is just a survey. So first thing is, what are the contraindications? We all have heard about how to do it, but are there actually any true contraindications for EBUS TBNS? I've given 4 scenarios here. So one is a person who underwent PTCA and on dual antiplatelets, somebody who is having compensated type 2 respiratory failure. I think you can just make it into a... So and third is a person on ventilator but still has a large mass which needs to be evaluated. Somebody on maintenance dialysis. So this is all the routine patients you come across once in a while, other than the standard small lymph nodes and big lymph nodes. So I would request the audience to just poll whatever they feel are the contraindications. This is not a yes or no question, no correct answer, no wrong answer. This is just to understand. Then we will also ask the experts who are there what they feel are a strict no for EBUS. So are there any strict no's for EBUS? So many people feel that many of these can be contraindications. So we will start with Dr. Valiyappan. So for those who want to start EBUS TBNA, are there any contraindications to EBUS TBNA?
Going by the textbook definition, there are no absolute contraindications. But if there is a safety issue and you might not immediately act on the report of it. Say, for example, in a sick patient, you do an EBUS and diagnose a carcinoma of the lung in a mechanically ventilated patient. You might not be able to give him any therapy immediately. So in that case, it is better to wait. So if it can really make a difference, then yes, we can go ahead and do it. As regards to what I can see, most people feel that PTCA recently and on dual antiplatelets, yes, he is at a higher risk of bleeding. But more important is the diagnosis going to make a difference? And if that is going to make a difference, then it might be worth taking a risk. But otherwise, it is really not. Yeah.
Dr. Kedar.
I actually don't feel that there's a need for EBUS for a person in ICU and mechanical ventilation with a large subcarinal mass. It's more a central airway issue. And if you go in with your bronchoscope and you're able to see some kind of infiltration, and EBUS is absolutely unnecessary, unless it's a staging kind of a situation. But even then, with a subcarinal mass, you're talking about N2. So I would question the need for an EBUS. I would agree with Valiyappan on the first part of it. I would consider, everything is a relative contraindication. In hemodialysis, I would be more careful, largely because of the platelet dysfunction that most patients tend to have. I think as interventionists, we've seen bleeding. While every day morning, I know you pray very, very hard that your patient doesn't bleed, Nagarjun. I too do the same. So unless we know how to manage bleeding, we shouldn't become interventional pulmonologists. So most of it would be relative. For me, I would question the need in the large subcarinal mass in this, 4 situations.
Yep. So I think most of them are correct that there is no absolute contraindication. No, this is not the poll. Yeah. So the second, so only thing is that it's all a risk-benefit ratio, I would say. So if you go by the guidelines, there are no strict no-nos. If you feel that it will benefit, you still can do. There are people who have done on antiplatelets or people who have done in relatively sicker patients, but we should always assess whether it is actually beneficial to the patient.
I'll just add to this, Dr. Nagarjuna. There is no emergency EBUS. EBUS is an elective procedure. So once you optimize your patient from individual point of view, definitely.
I think it is very correct. So there is nothing called emergency EBUS. I think this is something which we should all remember. Unlike central airway lesions, so EBUS is always an elective procedure. So whenever possible, I think we should try to stabilize and do. So the next thing is what investigations should be performed before EBUS TBNA. So this again, I think people are variable in what they order for. So coagulation profile, CBP, viral screen, creatinine, any more investigations which people feel. So again, I think this is again just a survey of what people think is correct, what people think is wrong. So I think we'll just go. So this is what the audience or everybody who has been there practicing feels. So I will ask Dr. Titivat at his center. So before EBUS, so what are the basic things which we should ask for? This is more on a safety grounds, I would say.
So actually we get the history. If the patient is fine, no medical history, we don't get any blood test. We just go ahead, do it, and do the universal precaution for the HIV and things like that. But yes, if a patient has diabetes, OH, CKD, then we get some CPC, some creatinine coagulation profile. But the HIV and the viral test is not required in our center because we do universal precaution anyway. Yes.
Dr. Pawan he's from Tata, so they do a lot of staging EBUS and EBUS procedures.
Yes.
So at your center, what is the basic things which you order for?
Absolutely agree with the audience because more and more smaller nodes you want to target, you want to avoid bleeding. So I would like to know the coagulation profile of an individual patient. Viral screening are done as a universal precautions in our institute. HbSCG and HIV, HCVs are must. Creatinine, yes, definitely. Creatinine and LGBT are two things we look at. Creatinine for the doses of the anesthetics which we are going to use, as well as if you are expecting dysfunctional platelets, especially when the urea and creatinines are high. So I agree with the audience. This is the minimum thing, and ECG is added when you are using propofol and general anesthesia, especially when you are targeting multiple nodes.
I think he's very correct. Samir, please.
Yeah, so I think so some centers are doing it under general anesthesia, some centers are doing it under sedation, so that's one difference. And also, what are the basic requirements for doing a bronchoscopy at your center? So the same apply for EBUS TBNA. So if they are doing universal precaution for every patient, you need not do this. But I believe in our setup also we have to justify the procedure, justify any complications if they turn up. So I think so in the Indian setup, we should go ahead with all of these.
Basic things. I think so at our center also, this is what we basically follow, the bare minimum. But if the person is elderly or has some cardiac issues, we definitely get an ECG and 2D echo, more on the safety grounds. But if you look at the guidelines, it doesn't say actually that even you have to get a PTI and a APTT also before EBUS. EBUS is considered to be...
That's what I wanted to ask. So do you withhold procedures if the coagulation is abnormal in a young male with a sarcoidosis?
We do order, but if at all there is stark abnormality, we think, okay, why does he have an abnormality? And we definitely try to look into it. So I think this is what we follow, but there are no guidelines. See, the question is framed only because there is no guideline on what is the bare minimum. But this is what we follow at our center. I think everybody is wrong or correct in their own way.
Just to add, Valiban, since you guys see so much of sarcoidosis and have published so much, don't you guys as a routine do ECG in your patients? Because cardiac sarcoidosis is so much underdiagnosed, and at our center we pick up so many. Every single sarcoid of mine, we send it to our electrophysiologist, and they see. And we picked up so many more cardiac sarcoidosis which we would have otherwise not. So
We,
you still don't think that
we
ECG
try
would be
to
mandatory?
get a ECG done routinely, but we do not get it interpreted from an electrophysiologist. And we haven't picked up that many sarcoidosis, and we don't. I don't remember cancelling at least any patient for a suspected cardiac this one. And even if we send for the cardiologist for a clearance, I haven't seen them do anything further
So,
to.
so
increase
here's
the
another
safety.
interesting point. A lot of these patients, at least at my center, have had some kind of a rhythm disturbance for which an ICD was inserted. Many years later, when they come back for their follow-ups, they actually send them to us for assessing mediastinal lymphadenopathy to see if there's lung involvement in it. And in retrospect, the ICD was actually inserted for a cardiac sarcoid rhythm disturbance. So this is also something interesting. And now, as a practice routine, I'm sending all my suspected sarcoids for both eye and cardiac screening.
Correct. I think that's a very important thing when you suspect sarcoid. Actually, in our center, after you prove sarcoid, we do that, not when you suspect sarcoidosis. But nevertheless, moving on to the next question, this is again a lot of variability. So, what is the ideal level of sedation for performing EBUS TBNA? So, I request everybody to quickly put in what they feel is correct. So, I worked at PGI where we had done under bronchoscopist driven conscious sedation. And now I practice in this hospital where it is anesthetist given deep sedation or anesthesia. So I think it is just a survey. So we will also ask our experts what they feel probably is correct. So Dr. Nitesh, so what do you feel? This is what most of the audience feel. So this is just a survey. So you can keep answering. So minimal means that the person is widely awake. Moderate means he wakens up to call. Deep means he wakens up to painful stimuli, and general anesthesia is general anesthesia. We'll also ask somebody from the non-government setup also. I think we have people part of the
Yes,
this thing. So first, Dr. Nitesh, please.
So we do it under moderate sedation. Majority of the cases, hardly in a month, 1 or 2 cases we take for deep sedation and in the OT. The main reason being the logistics of arranging, shifting every instrument into the OT, and we are more confident when we're doing in a moderate sedation. Yes.
So now we can ask Dr. Rohan or Dr. Varun at their hospitals. So I think they're not from the government setup. So in the non-government corporate setup, so how would you?
We most of the time do it under deep sedation. We like to have the patient comfortable, not coughing, minimal recall of the procedure, and also it gives you the time and ease of doing procedure. You wouldn't want a patient coughing and you keep doing the procedure and struggle with the procedure. So I think deep sedation with or without artificial airway is where most of our cases happen.
So I think Dr. Varun also one quick comment before we move on.
Yeah, so moderate is an indication is a what? Like moderate sedation is quite enough. You want to sample the node, 1 or 2 only, and that is a previous malignancy or a non-malignancy TB or something like that. If you want to do a staging for that, it's a longer the duration. So at that time, the deeper sedation is required.
I think his point is also very, very correct. If you plan a longer procedure, you want to do something like a forceps biopsy or a cryobiopsy, I think having a little deeper plane is better. Second important is the patient preference and comfort. If the patient wants more comfortable procedure, probably a slightly deeper plane. But if you look at the evidence, there is no difference. This is all the papers, lot of papers that moderate, deep, GA. The diagnostic yield is not going to change. So I think it all depends upon the operator and the patient's preference. We have heard from Dr. Titivat also that at their center also it is moderate sedation. Am I correct?
Yes.
Yes. So I think you should individualize your practice, and you should sit with your anesthetist and then probably take a call. Then this is something which has been briefly touched about. Again, very important thing. So when you do not have rows, I think if you have rows, it makes your job much easier. I think we have a session on rows. But if you do not have rapid onset evaluation, so what is the ideal number of passes which needs to be done? 3, 4, 5, and 6. Already we have heard from Dr. Titivat that he does 5 passes per node. So again, I will request Dr. Valli and Dr. Pavan to comment on the ideal number of passes when you don't have rows.
If there's no rows and there are multiple nodes involved, I would prefer 2 or 3 from each of the nodes. If a single node is enlarged, yes, maybe I'll go up to 5 or 6, believing that at least 6 in total for a procedure is what is the minimum which we consider. Either if there are 3 nodes, 2 per each, and if there are only a single node, then 6, or if there are 2 nodes, I'll do 3 or 4 in each of them.
Wali comes from PGI, which is a very high volume center. They do EBUSs on a daily basis, so that is what they follow. Again, we will ask Dr. Pawan.
So for lung cancer,
Comes from an oncologist center, so what is their perception of ideal number of passes to get
yes.
the...
So it depends on the how good is rapid onset evaluation person as well.
Yes.
So we
No, here we don't have rows.
Yes,
in
okay.
this question.
So minimum 3, what we do, I've sent first 2 passes for the slide staining, and I send 2 passes into the formalin just as a core sample. So minimum 3 plus 1 if at all my rapid onset evaluation, there is a question on diagnosis. If I do look at the benign pathologies like tuberculosis and all those, then I send 1 pass for the rapid onset evaluation. The second is for formalin into histopathology and 1 into microbiology. So usually 3 is minimum what I recommend.
So I think he has brought a very important point. Passes are not only for diagnosis, passes are also for ancillary studies. It has become now imperative that irrespective of the diagnosis, whether it is malignancy or non-malignancy, you need to have ancillary tests. I think that's something which we should all remember. So we have to take more. Minimum 3 per node is what the CHEST 2016 guidelines recommend, but that is only for diagnosis, getting the diagnosis. Now here we want tissue for microbiology or the NGS or other tests. So it is 3 plus 1 or 2. So I would say that now I think at least 4 or 5 is what I would suggest. Any other differences in opinion? I think everybody feels the same. So I think this is again, there is no consensus on this thing. Now this is again, we have discussed about this point. I think we will just skip it for lack of time. Number of revolutions, actually speaking, there is no guidelines. As Dr. Titivat has said, if you are energetic, you might want to do more than 30 or 40. Otherwise, the recommendations say around 10 to 15, up to 20 is more than sufficient. Again, this is something where there's a lot of difference. I think here we can also ask the audience, what is the ideal suction which has to be applied? So most of us use the Vaclock syringe. Even in that, if you see, you can adjust the amount of negative pressure, 10, 5, 15, 20, 25. So should you apply it or not? So no suction, 10 ml negative suction, 20 ml negative suction, or recently there is some data on directly connecting the wall mount suction to needle to get more material. This is called as high pressure suction. So I'll request, as the survey goes on, this is an ongoing survey, I will request Dr. Kedar, Dr. Samir, on what is their approach to the suction. What do they do? Dr. Kedar comes from NH Bangalore, again, which is a huge center.
Yeah. So I don't use negative suction at the beginning of my procedure at all. I use the capillary suction method. So we just withdraw the, the stylet, and then we look at the first sample and the return of it. If that's giving us good enough, we don't feel the need for suctioning. But I've also noticed sometimes that when you start suction at the beginning of your procedure, you tend to sometimes get more bloody samples and your pathologist keeps complaining. So I think it's a first one, always a capillary. That's the rule I follow. But then if the sample is not good, then we go about with at least start off with straight away 10 ml of suction pressure. That's my protocol.
Comments? So how do you decide the suction, or Dr. Samir, anyone?
So we go by 10 ml suction at the beginning. If it is bloody, then further samples are without suction.
Okay, I think, see, now we have seen 2 different ways. Kedar says first you do without suction. If you don't get material, apply suction. Dr. Nitesh says first apply suction. If you get blood, remove the suction. I think nobody is correct. I think both are correct. I think we have to individualize. So we follow what Dr. Nitesh does. So we first apply suction, or first we put a Doppler. So if you see the amount of vessels, if there are a lot of vessels, then we do without suction. If the material is not there, we apply suction. If there are less vessels, we start off with 20 ml suction. And if there's more bloody return, we go on decreasing the suction. So basically, the first pass determines the level of suction required. Samir, please.
Yeah, so obviously first comes Doppler. During the start, we used to use suctioning for each and every pass. But then now what we do is first pass, no suction. And then if you're not getting sufficient cell block, or at times you feel that the node is hard itself, So then you go for a 10 ml suctioning. But certain cases you just don't need suctioning at all, as in all passes with no suction.
This is a new thing which we have done. Not new, it's been there. It's called without suction capillary sampling. So you just remove the stellate slowly as you jab. So because of that negative suction also, you tend to get material into the needle. That is called as no suction capillary sampling. Correct?
Can you throw some light on the wall mounted suction?
Yeah, wall mounted suction. I have just read an article. We have never done personally because our wall mounts are not probably as technically sound as what have been used. If in our OT, if you put 40, it might give 80 also. But if you have a wall mount suction which accurately delivers the amount of negative pressure, this was the paper where they have said that in a necrotic node, where you're suspecting malignancy, if you do wall mount high pressure negative suction, the chance of getting a adequate material is more. So it's a very select subgroup where they have said that in a necrotic malignant node, you might get material. There's only one paper on this thing, but this is how people innovate and then try to get more material. I think now a lot of data on this, what Dr. Kedar and Dr. Samir were telling, just without suction, slow pull capillary technique. I think this is something which is also being widely practiced now to get material. So now one or two more questions before we wind up. Stillet. Do we need it or do we not need it? Because every needle comes with a stillet. Again, we will, as I think there is no correct answer again. So you can just type in what you feel is correct. So Dr. Titivat, I will start from you now. So what do you feel? Stillet is required or not required?
Yes, I think a stylet is required, and actually, when we put it into the TBNA into the lymph node, the stylet usually pull back a little bit, so we want to jamming the stylet before we remove it to make sure that we don't want the mucosa, the bronchial mucosa inside the needle. But yes, we use the stylet. Otherwise, I feel that even the stylet, the mucosa is a little bit inside the needle. So many times before we remove the stylet and start do TBNA, so we kind of jamming the stylet a little bit. Yeah.
So Dr. Valli, what's your opinion on the use of still? Because in a high volume center, every second counts.
The stillet, we use it for the first pass, as Dr. Titivat said. It clears up, especially if you puncture through the cartilage. If the needle gets blocked, it might affect the sampling and the yield of tissue. So that is the basic idea of why stillet needs to be used. But again, there is no data to support that the diagnosis differs with it. And of course, its time is a big difference. And there was one study which said that for each stillet pass used, it 15 to 20 seconds increase in time, and it counts when you have a lot of procedures.
So stylet, actually the data says that, I guess, please, Dr.
Yeah, the used to stylet, when you don't use the bronchial mucosa which stuck in the needle, and when you do a rose, that mucosa mimic with the adenocarcinoma, like larger the nuclei and the ciliate. So the using the stylet to prevent the bronchial mucosa to come in the smear, that is only the one indication I know. The second thing, I don't know the logic. I think it is a matter of the discussion. When we pass the needle and then jabbing the stylet and they come out. So whatever the people say is the contamination of the bronchial mucosa, we stucking in the lymph node. And again, we are aspirating the same path. So how is the logic is going to work? I don't know. But still, it's a debatable.
Not in the channel of the needle because it is somewhere outside. But anyway, so whatever the data says that stylet actually doesn't change the diagnostic yield. But as most of the experts say, and even we do the same technique, we use the stylet in the first pass to actually to send off whatever epithelial is, if at all they are there. So stylet, we also use it again after you take the needle out. Sometimes if the needle is jammed also, again sometimes you put the stylet to clear off the needle. And also stylet, as now most of us are using the capillary technique, so stylet again is required in that particular. Stylet is still required. I think now the last question for lack of time is from the experts, Dr. Titivat again. So how many procedures, somebody here wants to start doing EBUS independently. So how many should he have done, assisted, or be doing to maintain competence? Samir also.
So basically, actually, it's in the training procedure for the Thai society, which we part of this. At least a year, the fellow must have at least 25 cases to maintain, to reach the competent level, but then they have to maintain 50 cases a year around that. I think that probably will be experience.
So Dr. Samir or Kedar, who have been the leads in VABIP and this thing. So I think how many? I think linear EBUS is a procedure which is not very complex. For somebody who wants to start it, I think it is more of having the equipment with you rather than the technical difficulties in it. But still, Kedar.
I think during training, get your hands on as many cases as you can. If you want me to put a number, I would say anywhere between 25 and 50 a year should be decent enough. And again, that should be in the order of observed, assisted, and of course independently done with a supervisor around you. So I would put that number anywhere between 30 and 50. For maintaining your competency, once you've gained that level of confidence and you've done maybe complicated cases where you've done 11R superior, inferior, and gone after less than 0.5 centimeters of lymph nodes, I think even if you do about 10-15 cases a year, I think it is decent competency. I would call it, but I don't think that the numbers that the chest had given us a long time back are backed by any strong evidence as such. So the other thing I think that has drastically changed in this arena is the fact that now we have many more simulators available. So if it is a matter of competency and the number of cases, then I think simulation is the other way to go. So use your simulators to the best, see as many cases as you can, and assist, because this is an audience which is learning EBUS. I think, train yourself on simulators before you actually start, so you can cut down the number of numbers actually which chest quoted. And I think it has to be different for every country. We can't have a guideline which puts a number, because many centers may not be even having enough cases to justify that number at times with the number of trainees we have especially. So a number is very difficult.
Yes. So simulators, now that he has brought up, tomorrow we have both high fidelity and low fidelity simulators. So tomorrow on the workstations, I think all of you can have a feel of performing EBUS on the simulators also.
So as of now, chest and even VABIP both are very strongly recommending that you get trained on the simulators, because the advantage here is your dexterity for each individual node can be evaluated, and your competency of performing this particular procedure, unlike other intervention procedures, can be evaluated on a point basis when you do simulation. So simulation is something, and again, each country has a different number of patient case, and also simulation is the first requirement. 10 cases of simulation is what they say is what you should be doing, and you will be evaluated by your examiner on the same.
Yeah, thank you so much. I think this is some of the gray areas which I tried to cover.
Just one thing, sir, I would like to add is, before picking up a scope, if the learner learns what are the parts of a needle and how does a needle work, that is more important than holding the scope.
Correct. So I think
We have seen people, they have started Scopy, they have put the EBUS, but they don't know how to use the needle. And then they are calling us, sir, we don't know how to use the needle, please teach us. So learning the needle first and then the Scopy is the way I would suggest that that's how learners should go about it.
So I think for this very reason, we have another station only for needles. So where you can feel all the needles, see how they are locked onto the EBUS scope, and just to have a feel of it. So tomorrow, I think all of these things will be practically taught.
And just one more point to add. I also believe that every trainee, if you look at many of the learning curve diagrams that come out in literature, you'd find that some procedures, the learning curve is easier, some it is difficult. And it also depends on which station you're sampling. For example, a 4L would probably be much more difficult to sample rather than a 4R. So I think there are many factors that come in, and when there are so many factors, to put a proper number and say this is the competency level or the number on the competency level is really hard. So I think simulation is the way to go, and I think kudos to you setting up the lab here. So
Thank you so much to all the experts.